Okay, can everybody hear me? All right, okay, so we're gonna go into Q&A. So we're just gonna do a show of hands or A, B, C, D, and then I'll just go through it. Okay, so number one, a patient is given an IM injection of Atoh 5 for sedation. An hour later, he begins to exhibit the following behavior. What medication should be given to rapidly correct this behavior? Or you guys can shout it out too. Okay, so I heard benzodiazepine. Yes, so this is an acute dystonic reaction. So basically, what is a dystonic reaction? Definition is you have intermittent, spastic, or sustained involuntary contraction of muscles, and it can really involve any kind of muscles. So the guy on the left, he's showing some dystonia in his extremities. You can have it in your trunk. Sometimes commonly you see it in the facial muscles. It's rarely dangerous. It's more just uncomfortable for the patient. It can rarely become dangerous if you have like laryngospasm, but usually most of the time it's benign. But to basically prevent or reverse it, you can give benzodiazepine or Benadryl, and these are both anticholinergic to kind of fix the dystonia. And then if that fails, then you can use benzos.
I think one thing that's good to know about this entity is that one of the key features is that it kind of, you're off midline. It resets your midline. So patients can actually, if they focus on it, can bring themselves back to midline, but their resting position is off midline. So if you like, both of these are kind of good examples when you see them. They're kind of going to be in some way pulled to one side, and there'll be some asymmetry that'll kind of be a clue that you're dealing with that. And because of that, sometimes these get called in as labeled as stroke codes, and it's important to identify before you get going down that whole pathway of the patient getting rushed off to CT, when you can just give them a dose of cogentin or Benadryl and make it get better.
One good test taking thing to remember is that a lot of people are going to be looking when you take the test. This has been on the test many times. You're looking for the Benadryl, right? And they don't give you the Benadryl, so look for the one maybe that is just as good, if not better sometimes, the benzodiazepine. Right? They will never give you both of these together because they're both good. And after you treat them, always send them home on either cogentin, which is benzodiazepine, or Benadryl. Because if you don't, this reaction, even if you stop the med they're taking, can last up to 5 days. And I've seen it. I'll come back.
Okay, thank you, Dr. Jane, Dr. Weiner. Okay, so which of these antipsychotics has the least QTC interval change? So we talked about how antipsychotics can change it. So Zyprexa, yeah. So this is a graph chart from basically a study done in 2004 by Harrigan. Basically, they did an RCT and they basically measured the QTC before and after they gave an antipsychotic. And as you can see here, olanzapine has the least, almost none QTC change. Some of the ones that have a larger QTC change include Haldol, and then ziprasidone is also higher than Haldol, and then thorazine, which is one we rarely ever use, has the highest.
Just the one point, someone comes in on olanzapine especially, one thing to check always is if they've gotten hypoglycemic from it.
Yeah, as Dr. G was saying, for those online who can't hear, if a patient comes in on olanzapine, just check for hyperglycemia. It's gonna have a lot of metabolic symptoms. Okay, number 3. So it's a hectic night in the ICU, and one of the patients has started climbing out of his bed, ripping off his oxygen, and swinging out at nurses, typical. So you need the fastest acting sedative to be given intramuscularly. What is your choice? So I hear a lot of Versed. So this is a graph of actually the time of onset for these medications. So Versed is pretty fast, and of the benzos, probably the best to give, but ketamine is actually given even quicker. The onset is about 3 to 7 minutes. And then if you see, let's see, so midazolam, it's like 10 to 15. Haldol, which is one we sometimes give, is 20 to 60. So oftentimes when you give it Haldol IM, you might not be seeing the effects for a little bit. Obviously, this is in an acutely agitated patient who does not have any history of psychotic disorders, because it can precipitate psychosis if you give it to a patient who has a history of schizophrenia, et cetera, et cetera.
Which you never know.
Yeah, you never know. Dr. Sinner says you never know, so why would you give ketamine? Yeah, so I mean, I actually did see ketamine given once to a patient who had a history of schizophrenia, and he came in, basically he was a trauma patient, and then after he was given it, he started basically growling, and he had like a comminuted radial and ulnar fracture, and then he started moving his arm around, and just, he couldn't feel the pain, but he was becoming even more acutely agitated. Yeah.
I don't think that makes sense.
Okay, number 4, which of the following is considered a first-line therapy for alcohol use disorder? C. Yep, so C. So naltrexone and another one, acamprosate, are both FDA-approved first-line medications for alcohol use disorder. Does anybody know how naltrexone works exactly? What receptor it blocks? So it blocks the mu opioid receptor. It can be given as a monthly injection. This is usually after patients finish a detox program. But you want to avoid it in patients who have concomitant opioid use because it can precipitate withdrawal symptoms. And during treatment with naltrexone, you should monitor their liver enzymes because they have a risk of hepatitis and liver failure. Disulfiram is another one that we often hear about. It causes sort of those flushing, nausea, headache symptoms when patients drink alcohol after taking disulfiram. But it's second line because in studies, people have shown that it's not actually as effective, because obviously, you know, if you're not as motivated, you can just skip your dose of disulfiram and then drink alcohol and you won't have the effects. So you really only use it for patients who are highly motivated. Okay, number 5. So we have a 20-year-old male. He presents to the ED after exhibiting some bizarre behavior at home. He has no past medical history of his own. His parents note that when he came home from a party last night, he seemed very agitated. He began tearing apart his room while looking for his phone. His parents confronted him. He became increasingly agitated, and then he threatened them with a knife. So then they called the police, and then he's brought to your ED. They have not seen any similar behavior in the past. So he arrives in restraints. He's tachycardic with nystagmus. What is the primary mechanism of action of the most likely substance that has caused his behavior? Okay, so I hear D. Yeah, so this is PCP, and PCP is basically an NMDA receptor antagonist. Some of the other answer choices, like A, direct stimulation of alpha adrenergic receptors, is the mechanism for cocaine. And then the second one, B, increased release of norepi, and dopamine is methamphetamines. And PCP actually causes decreased reuptake of norepi, dopamine, and serotonin, which is answer choice C.
Yeah. Well, go ahead.
Oh, no, yeah. Yeah, so just a little bit more about PCP. It's actually related to ketamine. When it was first discovered, people were using it for like general anesthesia and induction, but then they saw that people had a lot of emergence reactions. So that's why its use was curbed. So like ketamine, you say to watch out for emergence reactions. For patients that come in with PCP, when they're acting more agitated, that's actually the emergence reaction that you're seeing. And then oftentimes we see vertical and horizontal nystagmus with it.
Yeah, I saw a lot of this back in the 80s at Lincoln, and they will come in really agitated, hallucinating, not feeling pain because it's an anesthetic. I remember one guy that it took me and 4 big, tough hospital police to hold, and this was a little skinny guy, smaller than me, because he didn't feel any pain or anything else. I've seen even people bite themselves and not feel it, trying to get out of restraints. And they'll be hypertensive, usually tachycardic as well. And they'll have this really impressive vertical and horizontal nystagmus.
Okay, number 6. So we have a 6-week pregnant patient. She's brought in by her husband for increasingly irritable behavior. While in the room, she snaps at her husband and is unable to remain still for the exam. He tells you that he's concerned because she has a history of bipolar disorder. She begins to lash out even more and slams her chair into the ground. After some verbal de-escalation, what is the next most appropriate treatment or management that you would give her? So I heard Benadryl. So obviously, for most patients, you want to use, but especially for pregnant patients, you want to use a sedative with minimal effects on the fetus and minimal side effects. So Benadryl is a category B drug and it has no proven risk to the fetus in pregnancy. Some of the other drugs here do cause fetal malformations. For example, Haldol can cause limb malformations in the first trimester. Lithium is teratogenic and it can cause Epstein anomalies, which is basically this tricuspid valve is misplaced and it causes a sort of heart abnormality. And the physical restraints, you want to use this as a last resort for any patient. It can cause harm to fetuses in the third trimester, especially due to the positioning that the pregnant patient is forced to lay in. Okay, number 7. So we have an 8-year-old boy. He's brought in by his parents for altered mental status. They found him on the floor of their kitchen with the contents of the medicine cabinet surrounding him. He's slumped over his dad's shoulder. He's lethargic, but he's responding to pain. Vitals are as follows. He has a normal temperature. His heart rate is 130. Blood pressure is 150/90. Respiratory rate is 26. And O2 stat is 99%. His pupils are 4 millimeters and reactive. Which of the following did he likely ingest? Okay, so we'll go by show of hands. Who thinks A? No, who thinks B? Okay, C, D, and E. Okay. So yeah, so this is an ingestion of THC gummies. So THC, it'll show you somebody who might be lethargic, sleepy, but arousable, but they'll have elevated vital signs. So you'll see tachycardia, hypertension, tachypnea, and no changes in their pupil size, unlike some of the other drugs that are mentioned here. And there have been increasing rates of pediatric overdoses. We've seen a good number in our own ED due to increased legalization and access and people marketing, THC gummies to look like this, which look very mistakable for normal candies. So some of the other options. So melatonin, you wouldn't see any changes in vital signs. Opioids, you'll have respiratory depression, and then you'll see pinpoint pupils. Our patient had normal pupils. Xanax, you'll also see respiratory depression. And Benadryl has anticholinergic properties, so you'll see anticholinergic toxicity. Remember, this is like hot as a hair, so you have a fever, blind as a bat, so you'll have unresponsive mydriasis and dilated pupils. And then things like Xanax, which was another one of the options, you'll see decreased heart rate and decreased respiration.
It's pretty unusual to get respiratory depression from an oral benzodiazepine when taken by itself. So it's usually in combination with another sedative hypnotic or when given IV, but it'd be pretty uncommon to just purely from a benzo by itself to get that. But the fact that the patient's tachycardic and has, other stuff going on besides just sedation, which you would typically just expect normal vital signs in coma from a sedative hypnotic, that's what really goes against it the most for this patient.
Thank you, Dr. Weiner. Okay, next question. Okay, so which of the following scenarios in a patient with chronic ETOH use should prompt an admission to the hospital? So A, fever, tachycardia, hypertension, B, intoxication with vomiting, C, mild tachycardia, tongue fasciculations, or D, normal vital signs, 1 seizure 6 hours ago. Okay, who thinks A? Okay, who thinks B? C, okay, and D. Okay, so kind of a mixed bag here. So it's actually A. So this is the only one where you have concern for delirium tremens. In acute alcohol withdrawal, you do want to watch out for a lot of these other symptoms here are things that would cause you to think about withdrawal, but this is the elevated vital signs are the ones that make you more concerned for delirium tremens, which is the most dangerous and life-threatening complication. But for most of these, you would want to treat anyways. Okay, so a patient is admitted to the hospital for community-acquired pneumonia. During his stay, he develops confusion and visual hallucinations. How many hours after stopping alcohol use does delirium tremens usually present? Okay, can I see a show of hands for 24? What about 36? 48? Okay, and then D, 72. Okay, so this is kind of a trick question. So you can get DT after 48 hours. If you look at this graph here, though, on the bottom, you'll see that DT, the majority of the times, it'll be after about 3 to 4 days. You'll see the majority of the cases. So that's when you have to be on super alert for it. And then it can continue on for 2 weeks where you can have rates of DT.
I mean, you can see some of the alcohol withdrawal obviously before that, but the true delirium tremens where they're delirious, you're right, it takes a while. So that's a very nice slide to see. Good.
Okay, so number 10, our last one. So we have an 18-year-old woman with a prior history of anorexia nervosa, and she presents with bradycardia. Her BMI is 14. She's admitted for inpatient nutritional replenishment. And which of the following is the main cause of refeeding syndrome? Hypokalemia, hypomag, hypophosphathylamine deficiency. Okay, so hypophos is the main one. It's the main cause of refeeding syndrome. So basically what happens is that phosphate stores are depleted during starvation. As we talked about earlier, you get hypokalemic metabolic alkalosis, especially when you are vomiting persistently. You also get hypomag, hypophos, but during refeeding, what basically happens is your cell is starved of glucose. So when you get glucose, or when you ingest glucose, or you're being refed, then you have the release of insulin, and then cells uptake phosphate, but that depletes your intravascular stores. So what happens is hypophos can result in tissue hypoxia, myocardial dysfunction. You can get arrhythmias from this and respiratory failure. Some of the clinical signs are heart failure, edema, shortness of breath, paresthesias, and even seizures. And that is the end.
Thank you.
Thank you, guys.